Thank you, Josh. First, actually, I just want to say thank you to the CICASA team for putting technical assistance together like this for us. I know we're all spread around the state, and it makes it really difficult for us to see each other except for when we go to Advocacy in Action. So thanks for all the effort you guys put into this. Well, welcome. My name's Maura Demko, and I'm the director for the Sexual Assault Services Organization here in Durango, Colorado. SASO has been around for 40 years, and we currently serve La Plata County, and we serve Silverton as well, which is in San Juan County. So our catchment is about 56,000 people, and it's beautiful and sunny down here. So welcome, and we're going to talk about medical advocacy. I think it can be a challenging topic, and it can also be very interesting. So thanks everybody for joining us today. So let's start with just to understand what we're going to cover today. What is medical advocacy? And really, it's about working with clients, our victims that we serve who've experienced sexual violence, and we're working with them in the hospital or even a clinic. I know at different parts of the state for our area, and I'm going to talk a lot really about hospital advocacy, because our agency works with our local hospital, which is a Centura based hospital. And so we work primarily in our emergency department and have developed a SANE program. It's been a community response for 25 years it's taken to actually get it to where it is today. So it doesn't happen overnight, and it's been an amazing process. So we're going to take you on that journey with us. It really comes through, we're confidential advocates no matter where we are, and it can be a blessing, it can be a challenge, but it really is in service of working with the victims that we care for. And that stays no matter whether we're working with law enforcement or with the hospital staff. And some other things that we'll touch on are how we share information, give referrals out, do some safety planning, but everything is always in the best interest of the victims that we serve. Before we really start talking about our personal process or our process here in Durango, I do want to touch or really recognize that we had a change in reporting options in 2015, and Senate Bill 128 was produced, and we're very excited about that. I know there were developments for domestic violence victims in the last year as well. But what we were finding, and this is when I started here 5.5 years ago, is when we had someone come forward and report that they had been sexually assaulted and they wanted medical care and a forensic exam, the first person to get called in the emergency department was police or sheriffs, because the hospital wanted to know who was the jurisdiction that was going to be paying for the rape kit. So I think this was pretty common around our state. And really, it did pose a challenge for victims coming forward, because the first thing that they're faced with is a police officer or law enforcement officer. And for somebody who's just experienced the trauma of sexual violence, that can be really intimidating and daunting. So out of a lot of our trauma work, understanding trauma more effectively, this was proposed to the legislature, and Senate Bill 128 came forward. For us, that means that the first person called in our emergency department is the SANE nurse, and the SANE nurse calls our advocacy agency. So new reporting options are people can have the choice when they come forward for a forensic exam to either work with law enforcement and participate with the criminal justice system immediately. They can do a medical report, which is forensic evidence collection. And sorry about that. Forensic collection and medical care at the hospital, and that information would be available to law enforcement, but it doesn't mean that the case is going to move forward or be prosecuted. And then the third one, which is our new, really amazing option, is that they can choose to do an anonymous report. So in that moment, when they're coming forward and they want medical care and they want evidence collection, they don't have to make a decision on whether or not it's going to be given to criminal or given to law enforcement and it's going to be carried into the criminal justice system. And then the last thing that they can do if they really choose is just get medical care, and they won't have any evidence collection, there won't be any report. or information collected. Um, these have been really important choices for people coming forward because it is intimidating if you're faced with a police officer first thing. And so it really gives that choice and power back to the victims that we serve. We've seen it be very, very effective. I don't have our statistics from 2017 yet. We actually are just putting that together, and we're going to track each of the anonymous cases. We did do that for 2016, and in our area, we had 4 cases that reported anonymously. And out of those 4, and this was out of 53 cases actually, for the year of 2016, out of those 4 anonymous reports, 3 of them actually converted. And converted just means that it went to a law enforcement report. It does not mean that it was picked up for prosecution. So as we start talking about advocates and their response, I thought that it would be interesting. Our agency uses the CICASA manual when we do our training for advocates, and we do a 30-hour training for each advocate that comes through to meet our state statute requirements. Because those manuals are really big and there's a ton of information in them, and we still find them very useful, very effective for our volunteers, we put together a small handout or a handbook that we give to each volunteer, and we have printed every year. It's ranging somewhere around 35 to 40 pages. But it has specific instructions for each advocate in different situations that they may encounter. It starts talking about how do you handle a phone call, talks about the sexual assault, sexual violence continuum, talks about working with male callers or being responsive to LGBTQ needs, working with Native American population, Latino outreach. So different cultural things we need, but also some of the basic procedures that we use when we're on site and responding to the needs of a victim. So for us, how do we actually get those calls? So someone may call into our hotline and they're going to ask for information, or we may get a referral call from a law enforcement officer who's just met with somebody and taken a report, or we could get a referral from the hospital, which means they just say, we have a client here, we need an advocate. So if it comes through our phone line or our hotline, often what we find is clients will either have just experienced sexual assault, probably within the last 12 to 24 hours, or often, and more often, they wait 96 to 156 hours to come forward and report. We know that happens more often than not. Just because of the issues around, did this really happen? They're working their process. They may talk to friends about it and realize, yes, they did experience sexual violence and they do want to come forward and collect evidence and get care. So what we always talk about, some key points are, this is always a client-driven conversation. And some key things that we like to ask are you in a safe place? Can we actually talk right now? What do you need that would be supportive? And then we talk about the process of going to the hospital, what that actually looks like. Most of the time people will ask questions around, what is a SANE exam? What do I need to do? Where do I need to go? So we really try to give them all of that information in detail up front. Of course, that's going to be different for each of our jurisdictions and areas and the clients that we serve in the communities. So we end up with a client who they really want a forensic exam. So they come forward and they're like, yep, we're in. What do we do next? We talk to them, we agree to meet at the hospital. In our hospital area, we actually talk about, do you want to meet in the lobby? When you get there, there is an information desk. You can let them know why you're there and get checked in. And then we'll meet you. They take them back to a private room. We walk through those steps so that they know what to expect when they get there and know that we'll meet them either in the front or in their private room, one way or the other. We also give them information on what may be expected as far as, please don't brush your teeth if this was a recent assault, please don't shower, don't change your clothes, bring those with you. And if there's somebody that you want there as a support, please invite them to join you as well. They're welcome, and we really want to support you in taking care of yourself through this process. The diagram on the right of your screen, we actually use that in our handout or handbook, and it's just a nice little flow chart that helps people figure out, so if they want to go to the emergency room, what do I do next? If they don't want to go to the emergency room, what do I do next? And then if we get to the emergency room, what's our next steps? This has been really helpful for the advocates that we actually work with. And truly, for a lot of the advocates, I think one of the scariest things that we're working with is a hospital call, because there's a lot involved with it and there are a lot of unknowns. So we really try to educate our team so that they're best prepared to show up and provide the best support they can. So a couple of these points I think I've already touched base on, but we remind them not to bathe or shower if they haven't. What we're finding now is that that doesn't necessarily matter. So if somebody's already bathed or showered or brushed their teeth, there's still potential to collect evidence. But we know from a police perspective, from an evidence collection perspective, these are best practices, so we still recommend them. We explain putting things in a brown paper bag. We don't put them in plastic because if they're sealed in plastic, over time, if there's any moisture, mold, and different bacteria can affect the evidence and it can destroy it. So law enforcement use paper products so that things can dry naturally and it still preserves the evidence that's been collected. We also talk to them about how participating in a SANE exam is really about getting medical care and knowing that their body, that they're okay, and if there's anything that needs to be attended to, it can be. Because it doesn't mean that they're going to necessarily choose to prosecute this case. We also, many of us who've been in the field, know that from a prosecution perspective, it's not always picked up either. So the key important part is medical care and safety and attention to the victim and their needs. Again, if they have a support person that they'd like to include, we really encourage that. And when we've answered all of their questions, we end the call and agree to meet them within 20 minutes if that's feasible. Our response time to get to the hospital is actually 1 hour from our call. Often we can usually make it there somewhere between 30 minutes and an hour. So we just try to be as accurate as we can, give them as much information so they're prepared and they feel safer walking into that situation. So what does that mean for an advocate? Now you want to get your items together. What's your go bag? We actually encourage all of our advocates to prepare a bag that they take with them. And some of the things that we suggest including are having a notebook so that they have a place where they can take down information. And it can be information for the victim, or it can be information that we need to follow up for them, whether it's a phone number, contact information, case number, the SANE nurse name, law enforcement officer, the medical doctor. We try to gather as much information as we can without being obtrusive so that we can help them follow up afterwards. Mainly because we understand that during times of trauma, our brain, our memory may not be working as efficiently as it might be in an average situation. And so we want to figure out what we can do to support them with that. In addition, we'll take notes and then send them home with their case number. I know, depending on where you are, the SANE nurse will do this as well, but sometimes there are other bits of information that might be helpful for them in documenting that they can take. SASO actually has a sheet that's there and it's available for our advocates so that they can gather information if they want to, and we call that our outreach advocacy plan. Personally, I don't actually do that because I have a lot of history around taking information and doing mental health assessments. So I have my own way of processing that. But I think everybody needs to find what works successfully for them. If we are taking information down, we like to remind the victim that this is completely confidential, that we only use this for follow-up purposes, and we destroy any of these papers when we're complete with them. Bring a pen so you have something to write with. Kleenex. Our hospital actually puts these in the hotel rooms. Listen to me. In the hospital rooms. I wish they were hotel rooms. Wouldn't that be nice? So they keep Kleenex in their rooms. But if you know or you aren't sure if that will be available, it's a good thing to have as a resource. We encourage our advocates to bring their advocacy handbook, and then release forms so that we can communicate with the SANE nurse. Due to HIPAA requirements, often that becomes a barrier. So if we can do that for a 24-hour period, that gives us some leeway to gather information. It's always up to the victim whether or not they're comfortable with that. Our agency information, we make sure to have brochures. We like the CCASA Survivor Handbook. We give that to the clients that we work with. You can print that off the internet as well. But there's a lot of really great resources, and it can help people understand the process and normalize what their experience is. We also have something called Note to the Closest, so that they can help people around them understand what they're going through. Our advocates bring a resource guide. We have a spreadsheet that we collect and vet information on. It's got hotlines, housing resources, food resources, therapists, a number of different items, so that if they have questions or if there's something that's needed, sometimes we need to help arrange transportation for somebody after the exam. Other times we need to help get them a hotel room if they don't have a safe place to return to. So we bring all of that information with us. And then other things, I've had different advocates, some like to bring cards with them. I was on a hospital call recently, and our local electric company actually donated boxes of kids' toys to the emergency department. So they had a box of puzzles and Play-Doh and finger paints and different things that little ones can play with, which I thought was pretty amazing. That was a new addition this year. And anything else you need personally, and then head out. So then we get to the hospital. First, just some prep reminders for each of us. Take a deep breath. Make sure that we're in a present space and that we're in a place where we can go in and actually be fully alert and there for the client that we're working with. Remembering that empowering the victim is really the key and the foundation of the work that we do. They've already had their choices taken away. We know that systems can be super challenging, and so very important to put them first, make sure that their voice is being heard, and that we represent that the whole time that we're present. Remembering that we're mandatory reporters if our client is under 18, and that medical professionals also are mandatory reporters for under 18, but they also are for 69 years or over 69. That was a new mandate that happened 2 years ago. And so that statute, if there's a suspected abuse or there was a violent situation, actually for people over 69, it even includes like bank fraud. We don't actually, that statute doesn't apply to us as advocates, but it does apply to medical professionals. And so it's really important to be aware of that too. Reminding ourselves that respect and compassion for those that we serve is really key. I think all of us have the best intentions, but so often the people that we work with come from all different walks of life and different experiences. And so finding a way to build rapport and connect is really important, but also honoring where they are. And knowing our trauma responses can be really helpful. I can't tell you how many times I've sat with somebody and they've just experienced a sexual assault, and sometimes they could be crying, sometimes they could be completely flat in their response and their affect, sometimes they could be laughing uncontrollably, and really just normalizing what that experience is for them and that there's no right or wrong there. So we get to the hospital and we want to find our client. So they may have been checked in. In the case of our emergency department, when you walk into the lobby, unless you came in through an ambulance, when you walk into the lobby, there's an information desk. And so our clients usually check in there, and they have a different protocol than somebody who's coming in to get medical care. So they're escorted back to one of the patient rooms in the back part of our emergency department. The idea is to keep it private, to really respect their space. And so that area was chosen instead of putting them in the busier part of the emergency department. In addition to that, our hospital, when they built and opened the hospital, probably like 8 years ago, no, I bet it's 10 years ago now, they agreed to put in a SANE room. And so we have a patient room that's designated for sexual assault forensic examinations only. And usually the patients are put into the room right across from our SANE room. So often when we walk into the hospital, we check in with the front desk. Rarely do we actually meet somebody in the lobby, but it happens sometimes. And especially if it's a client who still has some questions around, is this really what I want to do? So if we get there and they aren't there, or if they've already been checked in and put into a patient room, we'll check in with the front desk staff. We'll go, and we have a separate desk that fields phone calls for all the nursing and medical staff. We call them the hot seat tech. We go check in with them. If they aren't there, we find the charge nurse or the medical nurse who's treating and do a check-in with them so they know we're there as an advocate. We introduce ourselves to the client, go back to the room, let them know we're there for them, explain what confidential community advocacy is about, and our role in the situation, where we'll talk, where we won't talk, but we give them a really clear overview of what we do. Make sure that you know as an agency what your protocol is, because everybody has a different expectation, experience, and I think that that not only helps our advocates as we're doing this work, but it gives us confidence in holding space for the victims that we serve. And then something to remember is no hospital can refuse medical care to any patient, and especially a sexual assault client. Sexual assault cases are classified as a trauma, and so therefore should be receiving a higher level of care in the emergency department. It's, believe it or not, that's something that we've encountered down here prior to us really establishing our SANE program, and we held strong with that. And the win has been, we actually have an almost full on-call schedule filled with nursing staff who are trained as SANEs, and now we actually have a sexual assault nurse examiner coordinator who coordinates those schedules, makes sure that there's training. So know those parameters and hold your people accountable to them. It's all about the best practice for the victims that we serve. And remember that everything about this is constantly evolving. Just when you think you've got something worked out, I promise you something else will show up. So medical staff and SANEs, their responsibility as far as their clinical care covers 3 areas. First, medical, which that means treating medical injuries, making sure that if there's anything that's life-threatening, that that's addressed first, then evidence collection, and then discussion and referral for STI, HIV prevention. Sometimes that means pregnancy prevention, or it even could be testing to make sure that they're eligible for STI, HIV prevention, and then making sure that our clients have follow-up medical care if they need it. Next, it would be psychological care. Everybody in this situation, well, I would say an advocate and a medical professional, our goal would be to relieve stress for the client. And what we know is when clients are responded to soon or immediately after, it actually does decrease the potential for them to develop PTSD. So what we're doing is making a difference. Let's see if I can, moving this over, there we go. Really using the social work staff if they need to from the hospital. Sometimes that may not be available. Very rarely do we actually have social workers show up on our cases because so often we're working after hours and our social work staff are on 9 to 5 or 7 to 4 because we're a rural community. And then the great thing about the psychological care that SANES can offer is that they really are trained in trauma work and they understand sexual assault. So they bring that expertise to working with a client where so often when I've worked with medical professionals who are in the emergency department, people are really afraid and they don't necessarily have the knowledge of working with sexual assault or understanding the trauma. And so they either pull away and withdraw, or they can be really overbearing, and anything in between. So those are some really important gifts that we get out of working with a SANE trained nurse. And then the third part that they're responsible for is legal support or legal care. And the hospital staff is responsible for the evidence collection. And they're responsible for creating a legal record and document that will be used in carrying this case forward. They're part of the chain of evidence command. So they can sign off on the evidence collection and hand it off to law enforcement, and that is protected evidence. And then the last piece that they're responsible for is testifying in court. They can be called in as expert witnesses. We've worked with it frequently, and we have some amazingly trained SANEs who do an excellent job in our community. We're very fortunate. Oops, there we go. So next, it's important for us as advocates to understand where we fit into the process. So depending on your community, it may look a little different. So I'm speaking from our experience, but I think these are also great pointers that can help anybody in our community and yours. So initially, when somebody comes in, we have a responsibility, I should say the hospital has a responsibility to have their medical staff check in with the client. That's how our system is set up. It may not be if you have a private clinic that somebody's coming into. We're lucky enough to actually see something different. New Mexico does this very differently, and we're an hour away from Farmington, so I've seen other processes, but I'm speaking from ours. So the nurse will come in, and the doctor or the lead PA on duty will come in and check in with the client and see if there are any medical needs that need to be taken care of first. In addition, in our hospital, there's a medical nurse that's assigned to the case, and then the SANE takes over. We've reworked a couple of different points where they're actually taking advice from the SANE, and the SANE can administer STI prevention and prophylaxis for HIV. But hospitals have different protocols, and it's important for all of us to know what those are. So the SANE comes in, we've cleared medically, and they begin. They'll start by explaining what the SANE process is and what the actual exam looks like, and they'll give the reporting options to the client. So they'll walk through all of those 3 choices and even the choice of just getting medical care and not doing any evidence collection whatsoever. Once the victim decides what they want to do, so in this case, if they want to move forward, they actually will do signed consent releases for every step of the process. For the verbal history, for the written history, for every part of the exam, for pictures being taken, every bit of that. And we have our SANEs come in and actually train our advocates on that. And the advocates get to see the SANE room. We do a tour of that during our training. So none of this is a surprise for any of our advocates. Then the examination starts, and it first starts with a verbal history that gets written down. I've seen the nurses do it a couple different ways. And then they move into the other room. So right now they're still in the patient room, then they go over to the SANE, and they begin the evidence collection process. It's a head-to-toe examination, anything from hairs, fingernail clippings, they're looking for bruising, they do take pictures, and they'll complete a medical exam as well. If there's anything that they see that may need medical attention that somebody may not have come forward with the doctor, they'll bring attention to that and make sure that they get care. In this moment, they're probably also going to talk to somebody about if they're suspecting that date rape drugs were used. We know that those process out of the body within 24 hours. So they'll take a urine sample right there, probably before they even start the evidence collection. And that has to be sent off to the lab within 24 hours. So that has an immediate need response, and the same nurse will probably speak to that. And then once they've completed the exam, they'll talk with them about emergency contraception, STI prevention, HIV prophylaxis. As I said, to receive the prophylaxis, they actually need a negative, well, they need a pregnancy test, but that needs to be a negative pregnancy test for any of the medications. And then the nursing staff will look at the person, and if they disclose that they are suicidal, or if there's anything that is outstanding around a mental health need, maybe somebody has delusional thought, or they're presenting as actively psychotic, increased depression, they can make a phone call for a mental health exam. In our situation, we actually have an outside agency that they collaborate with. They have an MOU, and so the mental health center comes over and does that evaluation before the victim can leave the hospital. And then in a wrap up, and right now the way this is rolling is that our SANE nurses are also talking about funding. So the rape kit itself is paid for by law enforcement if they are reporting, law enforcement or medical. And so it's the jurisdiction where the crime actually happened. If somebody chooses to go anonymous, then we have an opportunity to request for SAVE funds, which are out of the Department of Criminal Justice. And so the nurse will actually take the information down and complete that paperwork. And then if we're looking at medical care and somebody doesn't have insurance or is not eligible for Medicaid, then we have other funds that we can look at. So if they're filing with law enforcement, then they're eligible. If they've created a law enforcement report, they're eligible for victims' compensation. Depending on your community, I don't know whether or not Victims' Comp will cover those medical costs. I know in our community, we have a pretty high success rate. And our Victims' Comp team is really amazing when it comes to working with victims of sexual assault. So we've been very fortunate there, but they will do it as a path of last payer. In addition to that, there's emergency funding that has come out through VOCA, and COVA, our state COVA, is managing that. So, but it has to be referred through your community advocacy agency. So for us as an agency, we would be able to do the paperwork and help somebody walk through that process to be eligible for emergency funds. It's a lot of information. And so the nursing staff will go over this with somebody. And as you can imagine, somebody who's experienced trauma and is showing up for this is a whole lot for them to take in. So they may remember pieces of it, they remember some of it, none of it, all of it. So we as advocates get to be that fill in the blank for them. And so it's really important for all of us to be educated on this and to walk in with the most information. And I realize that often our volunteers, they may or may not be able to hold all of this, but we as staff are the ones who cover those spaces. And then something to remember about the SANE itself, the examination, is that it's up to the victim whether or not they have an advocate or somebody that they care for present with them through the whole process. So they have a choice. They can bring in the family member. They can have us sit through it. I've had the experience of people who don't want me there. I've had the experience of people who do. I've had the experience of sitting behind the curtain while the exam's happening, but they want me in the room. And I've also had the experience of holding someone's hand. It's always up to the victim. And it's also up to your own comfort level, what you are willing to offer. So it doesn't mean that you're mandated to sit through the exam by any means, but if it's something you feel comfortable offering, then that's an option that you can put out there. And the other part to remember is that at any given moment, a victim can change their mind on any bit of this. They can start with evidence collection, they can do the verbal and written history, and they can decide they don't want anything else. That's okay. They can start with us in the room, and they can change their mind. That's okay. But remembering to honor whatever their wish is and empower them in the decision process is absolutely key.
Hey, Mara, we have a question.
Okay.
So the question is, what is the time frame for the completion of this process, the SANE process, from when the SANE comes in till the end of the funding conversation that you just talked about?
So for the exam itself, from when a SANE gets there, it really ranges. And I can tell you stories of when we started where it was 9 hours. Does that still happen? Absolutely. On the average, I would say it's 2 hours. So 2 hours from when the SANE arrives, gets the room ready, we've met with the victim, and then all of the process of the examination to when they're complete. Often if they choose to do STI prevention and HIV prophylaxis, what we're seeing is it's probably another hour. And it could even be a little bit more than that, because if they agree to that and they're seen as high risk, what our team has to have happen is they meet with the medical professional. So the doc has to come in, talk to them about the risks and of taking the medication, but also whether or not they're evaluating to see if they're high risk. And so they would recommend the prevention technique. Once that's done, they have to do a blood test to make sure that they're healthy enough, that their liver counts are okay, I think, and that they're not pregnant. And then they can administer the medication with follow-up to an infectious disease professional. So what we're seeing is somewhere around 2 hours, but that doesn't mean that's exactly it. It could be 4 hours, it could be 5 hours, it could be longer. And it really depends on each person and understanding that and normalizing that for the person. But that can also be really, really frustrating for the victim. They've just had this experience, they maybe haven't slept, they haven't showered, they haven't eaten. So our role and what we've taken on too is trying to buffer some of that. Sometimes it's sitting with them in silence, sometimes it is making sure they've got a lunch, getting them drinks, getting them warm blankets, what we can do to make sure they're comfortable. That's a great question.
Mara, we actually had another question come in.
Sure.
So it says, in Arkansas, we have specific extra documentation if the survivor discloses that they were choked or strangled. Is this true in Colorado as well?
You know, I'm not sure if it's extra documentation, but I do know, and I'm not SANE trained, you know, I'm coming from the advocate perspective. But what I do know is they do document and they have specific training around strangulation and choking, and that they do have to note that in the medical history and the injuries as they are doing the full exam. So I think my response would be check that out with your SANE professional, because they would be the expert on that. So a couple of points which we've touched on is really remembering to empower the victim and their choice. So if at any given time they change their mind, really honoring that. If law enforcement is present at the hospital, they are not allowed in the examination. Most of our experience is the SANE nurse working with the victim. Frequently, our advocacy staff, our volunteers, are in that process as well. Sometimes we aren't, but law enforcement is never present for that process. And that of course, the victim always drives what happens. So part of why I emphasize that so much is because when we're looking at roles in our community and who holds power, law enforcement definitely does. And often people will say yes or do whatever is requested of them just because it's somebody in a uniform. The other one is medical. So nursing and doctor staff, medical staff, we tend to hand our power over to them when we're in a medical appointment. And we will take whatever they say as word. So really remembering that it's so important for a victim to have their voice and to allow them to make decisions, even when they're working with the nurse, because sometimes they will look for that guidance, but putting that power back on them and reinforcing that is key. And then, of course, having really good communication with your SANEs and your SANE program. It can be super challenging because of HIPAA guidelines, and yet at the same time, our statutes in the state of Colorado, our umbrella of confidentiality is even more specific than HIPAA or FERPA. And so we have to be very careful in what we share. Our guide is always, we don't share anything, we take information in. But in the case of the best care for a client, having that release just to speak to the SANE for a 12-hour or 24-hour period can really help us with follow-up care for someone. And more often we err that in unusual situations where there might be something that we really know we need to follow up on, and we feel like there might be a question around that. More in the care of the client than for our own personal need.
Hey, Mara.
Yep.
So I'm pretty sure this was probably in regards to your discussion around law enforcement not being in the room. But will you speak to law enforcement advocates and whether or not they're in the room and kind of what's going on there with law enforcement advocates at the hospital?
So we have a unique community. That's a really great question. And I know with law enforcement advocates, it depends. So one of the challenges that law enforcement advocates have is everything that they do is documented and available to law enforcement, thus then also to the DAs and prosecution. And so we see that difference between being community advocates and being law enforcement advocates as very important. And I'm not in any way disrespecting the importance of a law enforcement advocate. Because we work with federal jurisdiction, we have 2 tribal reservations that are nearby, the Southern Ute Tribe and Ute Mountain Ute. We've had some actually really great experiences working with law enforcement advocates from their agencies. And what I've seen is that law enforcement advocates will be present. They may or may not be present during the SANE interview. And again, that really ends up being up to the victim. And I've actually had one situation where I had a law enforcement officer and a law enforcement advocate present during the actual examination. But the client was willing and open to that, and they had reasoning for it. They were not there for the whole examination, but they were there for a portion of it at the request of the victim. So I think that that's something that really needs to be addressed within each agency and for clarity around that, because sometimes victims may or may not understand that a law enforcement advocate, anything that is shared with them becomes part of the case and the report, law enforcement report. So I really feel very important, or I feel very strongly that it's important for that disclosure so that they're in a safe situation and that they feel supported throughout the process. And I may have some challenges with that. I think it's probably because I'm coming from a community advocacy perspective, but I also know that we work with the victims to actually disclose if there's something that we know would be important to the case just because of our exposure to so many different cases. So I see us as really working together in the process, but I also think that honesty and that transparency is really important as well. Hopefully that answers your question. And then I touched on this just as I was talking through the process. The nurse will actually wrap up the same exam, and they'll go over, after they've completed the forensic exam, they'll go over STI, HIV, prophylaxis options, blood testing, working with the doctor. And for some clients, that can be overwhelming. I know I've kind of touched on this already, so I'm not going to go into detail with it, but it's there just for you to think about and how that affects us. And then really being clear around medical care follow-up. When I started here 5.5 years ago, because we don't have a strong or a high HIV presentation in our communities, we weren't even offering HIV prophylaxis. It's as our emergency department has grown that we've seen that change, and we've had new doctors coming in with more best practice policies. And so it is an option that's offered, and especially for clients who maybe have partners who have drug use issues, they have drug use, they're using drugs, and they're exposed to needles, but they have that higher exposure potential. Or if the perpetrator is a known drug user and they are high risk, and they were exposed to that. So those are really important things to discuss, and our policy is that they actually, if they do choose prevention, or even if they don't, but they're interested in it, they need to do follow-up with our infectious disease department. So whatever your policy is, it's important to find that. So our wrap-up from the examination, and for us as advocates, as we're closing out that time with this person that we've been spending with, this time at the hospital with, what now? What do we do? Truthfully, I don't think people can usually get out of the hospital fast enough. When it's done, people want it to be over. And so for an advocate, it's important to make sure that you've got all of the information that you need, and so that maybe everybody can leave when the client has been cleared. But if not, you want to do a couple check-in points. So first, check in with the client and see if it's all right if we do a follow-up. Can we get a phone number? Is there a time? We know, kind of explaining that this is a pretty overwhelming process, and so we want to be there to answer questions and just check in and make sure they're doing okay. Is it okay if we call you? And is it okay if you don't answer for us to leave a message? Is it safe? Make sure we've got our contact information. Make sure that we've touched base on victims' compensation, and that's part of the reason we would follow up. The Victims' Rights Act. Often law enforcement, they actually have brochures, so do we. More often they've gotten them to them first. Sometimes our SANE program has a really nice folder that they give to everybody, but we need to make sure that they're aware of their rights as victims. Counseling referrals, we may write down a few names for them, or even for somebody that they can call in our office and do follow-up. So it may be in our paperwork, it could be in the SANE program. They may have a folder that they hand out, which ours does. We just offer things in addition to that. Making sure that they have a safe place to go. What's your agency protocol around safety planning with a client? And making sure that they have their needs met. Do they have enough food? Do they have transportation? And then also touching in on the self-care process. We really do try to touch base on making sure you have a really good meal, protein, something that'll help ground you. I've been a crisis therapist for a long time, so I advise, try to stay away from caffeine, sugar, and alcohol. Making sure you get a shower, you get a good night's sleep. Do something that is for you, that you enjoy. And I try to get them to speak to what that is. and that can vary with each person. And sometimes it means getting them a card so that they can get food, or making sure they have a ride home, or making sure they have a hotel for the night so they're safe until they can problem solve and figure out a better situation. And then we want to exit our situation gracefully, with respect and compassion for everybody who's been a participant. And then last, of course, but making sure to communicate that with our team. So who's going to do the follow-up, making sure the staff know, or the next advocate if it's going to be during that shift, but doing our handoff so that we know there's follow-up and we're following through on the things that we've promised. Very, very important. And if there were family members or friends who were there, or even if they have somebody in their life, and they're worried about sharing that with them, getting them information for the secondary trauma victims, or vicarious trauma victims. Making sure, do you have a brochure, a handout, web information? We actually have a sheet for Note to the Closest. The book that we supply them with, that CICASA actually produces, is fantastic. It even talks a little bit about helping with your family members, or, how do you talk to people? There's some great web resources. Do they need victims' compensation information? Making sure they've got a brochure, because your secondary trauma victims are also going to be eligible for victims' compensation too. And if they're really struggling with this situation, how do they support your victim that you're working with so they could be eligible for counseling? So, and that is a wrap up on just that experience at the hospital. And then, of course, whatever your protocol is back at the office for check-ins, follow-up, making sure that you're taken care of. I think so often, and I'm just as guilty of this with anybody else, that I forget to take care of me, or I try to compartmentalize it and then it builds up. So what do you need to do to take care of you? Do you need to debrief with your team? Do you need to go for a run? But really making sure that you take care of you as well. And then something else that I realized I didn't put in here that we've worked on as an agency over the last couple of years, we got funding through Rural DV, or OVWDV. And we got funding for emergency funding money, but we used it to buy bags for victims who come into the hospital for SANE exams. And we've taken the bags because their clothing gets taken. What was happening at the hospital was we had a bunch of donations from secondhand clothing stores, and we wanted to do something that was a little nicer than that. And so we put together actual gift bags for people, and it includes sweats, underwear, aromatherapy oil, lavender usually, socks, a journal, a little self-care booklet that we put together as a team, squishy ball for stress, a pen, different things that are really supportive for somebody and can create a self-care style, way of being, but giving them something that that's theirs, so they aren't walking out of the hospital in somebody else's clothing or in horrible little flimsy hospital underwear and socks with sticky stuff on the bottom of them, but trying to make it so that it's really more victim-centered and victim-caring. And I think that's probably the whole message from this overall is, how do we do this from a victim-supportive, victim-centered approach? And I think we all need to take the magnifying glass and walk through our process and look at that and make sure that's where we're coming from together. And then just some points for discussion. So that's really that really was the overview of how we've built our program and kind of how we operate on a day-to-day basis for medical calls. But there's some background in that too. And so that's where we are right now in these points for discussion. So a couple of things to remember in working with law enforcement. Really, we have developed and really worked hard on building our relationship with our law enforcement community. And that's everything from how they interview victims, to being able to talk to them on the street, to providing 5-minute blurbs, whether it's in their roll call, or providing ongoing community education, bringing them in to actually train our volunteer advocates so they're starting to build a relationship. Because what I've seen in some places, there's a lot of animosity between advocacy agencies and law enforcement. And truly, our goal is how do we provide best care practices for the victims that we serve? And so even when we're in a situation in a hospital where we may have access to information that a police officer, sheriff's officer, marshal might not, it doesn't mean that we have to, draw boundaries and lines. How do we build that relationship so that we're all supporting the clients that we work with? So for us, we have developed an education program. It's ongoing. We actually have an ongoing communication with our leaders. And if we are sitting with an officer and we feel like he's done some victim blaming or he's not victim-centered in his approach, we really do a lot of encouraging around FETI, the Forensic Experiential Trauma Interviewing process that Russell Strand has worked on. So some of our officers have had training around that. But if we do see an issue, we've gone to our supervisors directly and said, hey, we really noticed this. How do we improve this situation? So we meet with them directly. Actually, some of our supervisors, we have such a working relationship with them, they encourage us to actually meet with their investigators or their patrol or deputies directly and have that conversation so that we can educate them on what's a trauma response, why do people respond that way, what's their behavior going to look like, have you looked at FETI, can you do some training and outreach around that. And it really has been a support for us in this small community. They understand that we as advocates, we're super clear, we are confidential and we cannot share information, but we can take in anything. And so if there's something that they're looking for or they need, we can pass that along to the clients that we work with without any pressure and say, this is up to you, you get to decide. I know that they're wanting to ask questions. If you want to meet with them, it's up to you. But our goal is to grow their skills and ability so that they're doing a better job in serving the clients and not re-traumatizing them per se. They're actually being supportive. Know your community. I know we're all in different places. I know in cities it can be challenging, but it is so important to build those relationships with your medical providers. We have referrals from doctors' offices. We have referrals from docs in the ED. We've done education and training as continuing education credits around sexual assault and what to look for with our medical staff in the community. Build relationships with your SANE program. Know who they are. Have them understand what you do. Same with law enforcement and your DA's office. We're actually going to do, the end of February, we've gotten an agreement to do a trauma training for our DA prosecutors so that they're better understanding a trauma response when they're working with clients and they're having their prep meetings before trial or meeting with clients to go over charges. And we're really excited about that. That's been a couple of years in the making. So this was not an overnight process. It took 25 years for us to actually get a SANE program that is functional and working. More often than not, 6 years ago, we had spotty coverage. It was normal for somebody to be in the emergency department for nine hours. There wasn't a coordinated response. And we've been working in that direction for 25 years, and it's been worth it. We now know that if there isn't coverage, we have backup plans, and we're all in communication with each other. But for the most part, we actually have 24-hour coverage at our little local hospital. And then wrapping up, have your own protocol. Train your team. That is such a key part of the work that we do. And all of our advocates are amazing representations of working with sexual assault, understanding trauma, really wanting to provide compassion and respect and support for the victims that we serve. So we use our community to do that. We have a 30-hour state-mandated training, and we hold that responsibility, and it is very important. But we pull our community in so that the volunteer advocates, we just finished a training with 11 advocates, and we bring in our DA, we bring in our victim service specialist from the DA's office, who does victims comp and victim services. We bring in our SANE nurse, we do tours of the hospital, we bring in law enforcement, we bring in both police and sheriff representation. We bring in therapists to talk about the physiology of trauma or neurobiology of trauma. It's so important to provide that education, but you can also use that as an opportunity to build strengths and connections with all of our providers. And it's really been a huge benefit for us. It's worked for us. And then just know your protocol and be willing to share that, be willing to answer questions, but make sure everybody's on the same page so there's the same response. And it's done with respect, with compassion, and with a trauma care focus. So I wanted to leave, I don't know if I even have a minute left, but I wanted to leave an opportunity for questions. I don't have to go right at one in case anybody has more questions. And I'm really glad to share any information that we have. We love helping build other people up and build their programs. So use this as an opportunity and feel free to outreach if there's anything we can do to help. But thank you, all of you, for being advocates, for making a difference, and for supporting the clients that we serve. In my world, we're all unicorns, and I don't know how many of you have seen the nonprofit unicorn, but I know everybody's working extra to make a difference, and none of this would be possible without all of us. So just really appreciate all that you're doing.
Awesome. Thank you so much, Mara, for all of that excellent information. I am not seeing any questions at this point, so everyone can see her email address there on the screen, and then I also will provide that in the follow-up email. So if you have any questions after you processed all of the information that she spoke about, feel free to reach out to her. If you have any ideas about potential topics for CICASA to host for future webinars, please reach out to me. I just want to thank Mara for providing this presentation, and then thank you all for joining us today. And before I let everybody go, I just want to mention CICASA's next webinar, which is going to happen on February 7th at 12 p.m. It will be presented by Christy Kumar from Colorado State University, and she will be discussing a socio-ecological framing for understanding and disrupting sexual assault and teen dating violence. So please look out for the registration announcement in our e-digest. I hope you all have a wonderful day, and if you do have time, we would really appreciate if you fill out the survey that pops up when I close down the webinar. Thank you all so much for attending. Take care.